Right, so my name's Mark. I'm a hepatology nurse at Barnsley Hospital, and I'm just going to give you a brief update on hepatitis C treatment services in Barnsley area, and a quick update around sort of changes in treatment and treatment access. So hepatitis C is a blood-borne virus and is contracted from the infected blood of one individual to another. Main transmission routes are usually intravenous drug use and sharing of drug injecting equipment. Can be passed on in sexual contact between someone likely to be infected with hepatitis C. Blood transfusions prior to 1992 and tattoos, but there are a few other risk factors, and I've got a slide that we can reference to a little bit later on. At present, we offer hepatitis C services at Barnsley Hospital, and I also run an outreach service at Burley Court Drug Services in Barnsley Town Centre. We offer dry blood spot testing there, which screens for hepatitis C, B and HIV on a single blood spot test, or also we can send a venous sample to get a definitive confirmation of RNA. Hepatitis C RNA positive test on a venous blood confirms a chronic or a possibly acute active infection, and that sample is ideally should be repeated 3 to 6 months if it's likely to be deemed as a new infection, just to confirm that that is chronic. A positive antibody test does not always definitively confirm a positive infection, and it is the RNA that actually confirms that. An antibody test just confirms either previous exposure, and there is the possibility of a spontaneous clearance. Many people who are diagnosed with or undiagnosed with hepatitis C are not linked into care at present, and the aim of outreach servicing that we're doing at present in Barnsley is to try and capture more of those difficult to reach clientele. Sorry. So this is just a brief breakdown of patients that ideally we should be testing for hepatitis C and in turn hepatitis B and HIV. The links are very similar between the three. So as I mentioned earlier, current or previous intravenous drug use, we're finding particularly that patients who used drugs back in the 70s and 80s, who now no longer consider themselves a drug user, are coming back into services with a positive hepatitis C test, and are more likely to be patients that are attending with advanced liver-related conditions due to the ongoing issues of the virus. As I said, patients who have had in the past or are having sexual contact with people believed to be infected with hepatitis C are at around a 20% risk of contracting the virus. Received a blood transfusion before 1992, although I do believe that the large majority of the patients have now been traced, but there is the possibility that there could be the odd one or two still out there. People who have been in prison are at a significantly increased risk of contracting hepatitis C from sharing toiletry products such as toothbrushes, razors, and also other equipment that they use in prisons at the minute, tattoo guns, things like that are self-made. There is a high prevalence risk in men who have sex with men. Anyone that attends with deranged liver function tests of an unknown cause ideally should have a hepatitis C test added to their screen, which I assume most people are receiving a non-invasive liver screen through that route. Anyway, migrants from high prevalence countries, and also as I mentioned earlier, it's just advisable to be adding a hepatitis B and HIV screening, which is usually offered as a routine BBV screen, but also if we're doing it on a venous sample, it's worthwhile adding the testing on there. And I have popped a link on the bottom of this slide, which just takes you through the pathway from NICE in regards to who we should be testing. So just a quick reference back to the blood results that I discussed earlier. So a hepatitis C antibody negative shows that the patient's had no prior exposure to the virus, and only really worthwhile considering repeating if that patient has ongoing risk factors like drug use or close contact with people infected with hepatitis C. A positive antibody test, as I mentioned earlier, can show prior infection and may not mean that they actually have an active infection at that time. And that it's advisable that an RNA is obtained to confirm either chronic or acute infection at that time. But if their RNA is negative with a positive hepatitis C antibody, then that confirms a previous exposure and a spontaneous clearance unless they've received treatment. in that there will be patients that will attend that may have had the old treatment of pegylated interferon and ribavirin or one of the new drug treatments that we're giving. They will present with a positive antibody, and if treatment has been successful, we'll have a negative RNA, so no ongoing infection at that time. Anyone that attends and shows a positive HCV RNA can be referred to either my nurse-led clinics at Barnsley Hospital, or they also can be referred through to Burley Court, and we can consider offering treatment through my drug service clinic that we run there. Treatment-wise, there have been significant changes over the last 12 months, so we are no longer using pegylated interferon and ribavirin through any treatment regimes for any genotypes of hepatitis C. Typically, treatment is anywhere between 8 and 12 weeks and is most likely going to be one tablet once a day with a very minimal documented side effect profile, which are usually headaches, nausea, pruritus and lethargy. If patients stay well hydrated, they're usually tolerated quite well, and most people go through these regimes without any significant concerns at all. Success rate of the treatment is around 90 to 95% if it's taken as prescribed, and is an absolute cure for the virus. As I mentioned earlier, treatment-wise, currently we are offering it at Barnsley Hospital and at DISC, but we are hoping to sort of expand services over the next few years, possibly through pharmacies and other routes and channels that we do have. So far, in terms of treatment, the outreach service which we've set up has been quite successful. We have captured over 100 patients since October of last year who are previous or ongoing drug users. So we are finding that we're managing to capture a large group of highly prevalent people. But hopefully we are going to start identifying more people who are out there that have likely got the infection with an unknown cause. In terms of any questions or anything, I'd be more than happy for anyone to email me or give me a ring if they've got any questions or concerns about any patients. As I mentioned earlier, any patients that you think are suitable for treatment, then please don't hesitate to make a referral through to services. I will just give you a brief explanation of how to sort of make your way through the pathway that's been developed and is on the BEST website, so that if you do have a patient who you've got concerns about the results, or you just want to run through how to make a referral, if you go onto the BEST website, you can get there through two avenues. You can either type hepatitis C in the top search bar, and it should come up, and then you click the top link, which is hepatitis C, and it will take you through to the contact details for myself, and also if you click on the top link, it gives you the diagnosis and referral pathway. So as we talked about earlier, it talks about which patients should be being tested, depending on what results you get from those tests, and then sort of the avenues in terms of where you go for referral wise. But essentially, antibody negative, no need for referral into services, but would suggest retesting 6 to 12 months if they're a high risk candidate. Patients who have a positive HCV RNA, referral through to either Barnsley Hospital clinics, nurse-led clinics, or the drug service which is delivered at Burley Court in Barnsley Town Centre. And then I will pick up most of the sort of pathway from there in terms of access onto treatment, but usually it's relatively quick. Hopefully we aim to see a patient, do a non-invasive liver screen if it's not already been completed before they attend the hospital, aim to get an ultrasound scan and a FibroScan if possible. We're hoping to have access to a FibroScanner at Barnsley Hospital sort of over the next 12 months, which should hopefully speed up the process. And then from there, we will hopefully get patients onto treatment within 6 to 8 weeks of their appointment with myself. Just also to make a lot of patients aware is that we very rarely now do liver biopsies on patients. I know this is a fear of a lot of patients that do come to see me. They think that we're going to be taking biopsy samples from the liver. I've been doing hepatitis C care for 2.5 years now, and I've not biopsied a single patient as yet. So hopefully that we can reassure them a little bit that most things we do are non-invasive, other than the venous blood samples that we need. But again, we're trying to limit that as much as possible, and actually don't need to do bloods during treatment. It's just a case of monitoring them after that. Patients who are seen, the aim is to achieve what's called a sustained virological response. So we monitor their bloods on 2 occasions after their treatment course at 3-month and 6-month intervals. And if it's negative at that 6-month point, we deem that patient has cured the virus and is no longer infected.
What kind of compliance do you have with the Hep C interferon treatment?
Well, in terms of interferon, we don't use that anymore.
Okay.
So I've mentioned that on the video,
Right.
but and again I've talked about sort of the side effect profile of the drugs.
Okay.
Very well tolerated.
Mm-hmm.
8 to 12 weeks is the main treatment regime now,
And people tend to take it?
one tablet once a day. Very little side effects, and the compliance. I mean, I'm now treating in drug services.
Right.
These are patients that are actively injecting drugs, drinking alcohol. Some are not particularly got a permanent residence, and they're still managing to get through the treatment. And because there's the side effects associated with them, headaches, a little bit of sickness within the first few days, but usually settles. Some people get an itch, and some people have said they feel a bit more tired than normal, but sort of if they've not slept one night before.
And how often do people get reinfected with hepatitis C? Have you seen
So
that?
far, we have not had a reinfection of anyone that's achieved an SVR post-treatment,
Right.
but I imagine we're still only in the early stages. I
Okay.
think it's been about 18 months since direct-acting antivirals have been used. We probably will see that, especially now I'm treating in drug services. These are the patients that are still out there injecting, and I think until we get on top of that highly prevalent pool that's in the injecting drug using group, we probably are going to see a few reinfections. At the minute, there isn't a retreatment routinely offered for patients. One, because of the cost of the drugs, and the other side is that there's no there is some evidence that's coming out that there is a retreatment drug available, but we're not openly offering that out to every patient at the minute. So we emphasise when they're on this treatment that they need to stick with it for that 8 or 12 week treatment period.
Right. And if we get the Hep C result, because it is quite extensive, the antibody antigen, whatever, and if we're not sure, we can just ring you up on that number.
Yeah, not problems.
Just
But
to
I
help
think
with the interpretation.
one of the slides that I've put on
Yeah.
is just a very simple breakdown of
Right.
what a negative antibody means, a positive antibody, and a positive RNA. And
Okay.
I've put it in very simple bullet points around what it is
Right.
and what they need to do, depending on what that result is, really.
Okay.
But essentially, a negative antibody,
Yeah.
they've never been infected with the virus,
Yeah.
but could still be infected at that time. So you can
Sure.
sometimes have where they have a negative antibody, but they might have been infected 2 weeks or 4 weeks previous to that.
Right.
So the body's not yet developed the antibody against it.
Right.
So we'd probably advise, if they've got risk factors,
Uh-huh.
to recheck within 3, 6, 12 months
Right.
to see whether the virus is present there or not.
Okay.
Positive antibody, again, doesn't always mean that they're infected.
Mm-hmm.
It's just your immune response to that virus being present at some point.
Yeah.
It's the positive RNA that confirms. So a lot of people that you have had treatment before and have cured it, you may find that they'll come and have a positive antibody test,
Yeah.
but a negative RNA.
And if they have a positive antibody test and a negative RNA,
Yeah.
does that mean they can still be infectious to their partner?
No.
Or if they have a baby or anything?
No. So the antibody is purely just evidence of previous exposure.
Right.
It's only positive RNA that is the active virus that's there. The antibody is just your body's memory of that virus being present, as in chickenpox or...
Okay. And if they're hepatitis C positive, even if it is just the antibody, is it worth sending them off to the Spectrum Clinic for more extensive STD screening?
Again, I've mentioned on the video that we advise that everyone that we screen for hepatitis C should have a hepatitis B and HIV screen done with it. I mean, the routine BBV testing that we do at DISC has that as part. It's one pallet, I think, that you do 3 fingerprints on, and it's Hep B, Hep C, HIV.
Right.
Venous tap sampling, yes, we just say just to add it onto the test that you've sent through,
Okay.
just because the risk factors are the same sort of client groups, etc.
Okay.
So just to go through the other route in which to get through to the pathway. So if you didn't type hepatitis C in the top, if you go to the homepage, click on the gastro link, which then gives you a drop-down box for hepatology, and then the top corner is local pathways and guidelines, and it just brings you back through to the same route as going through for the hepatitis C at the top.